Imagine going to the doctor for a torn knee ligament, but instead of handing you a prescription for painkillers, they draw a vial of your blood, spin it in a high-speed centrifuge, and inject your own plasma directly back into the injury to literally regrow the torn tissue.
Yeah, which is an amazing procedure in itself.
Right. But now imagine using that exact same regenerative science on the clitoris.
I mean, it sounds like science fiction, honestly.
It really does.
But it is very much a clinical reality today. We're talking about utilizing the body's own, biological signaling mechanisms to rebuild these highly complex, incredibly delicate networks of tissue and nerves.
Which brings us to the core of today's deep dive, and we are so glad you are with us for this one because we are stripping away the glossy magazine ads and all the marketing hype surrounding a procedure that has just dominated the wellness space lately, the O shot.
Right, the orgasm shot.
Exactly. If you've heard of it, you've probably heard all the wild promises. But today, we're bypassing all of that. We've got a stack of clinical trial data, systematic reviews, detailed aesthetic guidelines, and our mission today is to look at the exact precise anatomy of this procedure.
Yeah, we're getting into the literal mechanics.
Right. We want to map out exactly where the O-shot is injected and, more importantly, why location is the single most critical factor for it to actually work.
Because the clinical data makes one thing abundantly clear here. This is not just a random injection into the general pelvic region.
Right. You can't just aim and hope for the best.
No, absolutely not. If a practitioner simply pushes a syringe into random tissue hoping for the best, the procedure will fail, period. The entire efficacy relies on millimeter-specific placement.
But to understand why the needle has to go into such incredibly specific calculated zones, we first have to understand what is actually inside that syringe. So what exactly are medical professionals injecting into these patients?
Well, they're injecting platelet-rich plasma, or PRP. And this substance is entirely derived from the patient's own body, which is a major, major factor in its safety profile.
So there's no risk of allergic reaction or anything like that?
Exactly. The protocol begins with a standard blood draw from the patient's arm. That whole blood is then placed into a specialized centrifuge, and the machine spins the blood at an incredibly high velocity to separate it by density.
Okay, let's unpack this because I know blood isn't just, red liquid. When you spin it down like that, you're separating out the different cellular components.
That's
right?
sort of the goal, yeah.
Yeah.
So the heavy red blood cells, they sink right to the bottom of the tube, and the clear, sort of watery plasma rises to the top.
Okay.
But sitting right there in the middle is this very thin, highly concentrated layer that clinicians call the buffy coat. And this layer is primarily made up of platelets.
Now, most people know platelets as the things that cause your blood to clot, right? Like when you get a paper cut.
Right, exactly. But their role is far more profound than just making scabs. Platelets are essentially microscopic storage tanks packed with growth factors.
And when you say growth factors, looking at these sources we have, it's basically an alphabet soup of proteins. We've got PDGF, VEGF, TGF-beta. I mean, what are those proteins actually doing once they're concentrated and released into human tissue?
They act as the body's ultimate biological directors. When platelets are activated in the body, they degranulate.
Degranulate.
Yeah, meaning they basically burst open and release all these proteins into the surrounding tissue. So let's take VEGF as an example, which stands for vascular endothelial growth factor.
Okay.
When VEGF hits dormant tissue, it signals the endothelial cells to start dividing and forming brand new microblood vessels. This process is called angiogenesis.
Oh, wow.
Yeah, and other specific growth factors in that buffy coat stimulate neurogenesis, which literally forces dormant nerve endings to sprout new branches, while others trigger fibroblasts to rapidly manufacture fresh collagen and elastin.
So we're taking the patient's own cellular healing mechanism, isolating it, concentrating it into this super serum, and putting it exactly where we want a physical upgrade. It's essentially like planting highly advanced regenerative seeds. You put these cellular seeds into the ground, and you expect them to sprout new blood vessels and new nerves.
That's a great way to think about it.
But any good gardener will tell you that the soil matters just as much as the seed. If you want to grow a dense network of nerve endings versus, say, pure structural support, you have to plant the seed in the exact right spot.
What's fascinating here is how practitioners identify that optimal soil. Decades of cadaver studies and human biopsies have allowed scientists to map the female anatomy on a microscopic level.
Wow.
They've identified the precise coordinates that are immunohistochemically proven to have the highest baseline density of existing nerves and microvessels.
So they already know where the hot spots are.
Exactly. The biological logic is simple here. The PRP needs a cellular infrastructure to interact with. If you drop these growth factors into a sparse dead zone, nothing happens. You must place the PRP directly into the center of an existing network to trigger that cascading effect of regeneration.
Which takes us to the first highly targeted zone on this anatomical map. Because the most famous claim of the O-shot, right, relates to enhanced sexual function, intimacy, and physical sensitivity.
Right.
So for a patient looking for those specific outcomes, where does the needle actually go?
To enhance sensation, the clinical guidelines point to the clitoral complex. But it's really vital to understand that the clitoris is not just that small external node most people think of.
Right, it's so much bigger internally.
Yes, it's a substantial wishbone-shaped internal structure. The protocol requires the PRP to be injected at the base of the clitoris, targeting the dense neurovascular bundles beneath the surface. And it is a highly structured, very geometric process.
Yeah, reading through these clinical guides, they describe making these injections using an ultrafine 31-gauge needle. That is a needle thinner than a human hair.
It's tiny.
The kind they use for insulin, right? But they aren't just doing one shot. They map it out almost like a clock face.
Right, the practitioner administers subdermal injections, meaning the needle slides just barely under the surface of the skin.
Okay.
And they do this at 4 cardinal points around the clitoral base, the 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock positions.
And the sources mention that by placing the serum at those 4 specific points, it creates something called a circumferential ring of blebs, which honestly, a bleb sounds like a typo to me.
It does, yeah.
But it's a real medical term for a tiny temporary fluid pocket under the skin, almost like a tiny blister.
Yes, exactly. And that ring formation is entirely deliberate. By creating these small pockets of PRP in a full circle around the clitoris, the practitioner ensures the growth factors completely blanket the entire neurovascular hub.
So they're surrounding it.
Right. And over the coming weeks, as those blebs absorb into the tissue and the proteins get to work, they stimulate new nerve sprouting and a massive increase in baseline blood flow directly to the primary center of female sexual sensation.
But the clitoris is only part of the equation for intimacy, right? The sources highlight a second internal location that is just as strictly mapped. It's the area colloquially known as the G-spot.
Right. The medical literature refers to this as the distal anterior vaginal wall. The injection coordinate for this area is roughly 1 inch inward from the urethral opening, specifically on the front wall of the vagina.
Okay.
And this goes right back to your analogy about finding the right soil. Clinical studies prove that the lower 1/3 of the anterior vaginal wall is significantly richer in innervation than the upper portions, or the posterior wall.
It's just wild to think about the level of precision here. Medical science is basically saying, hey, we know the highest concentration of nerves lives exactly 1 inch on the front wall, so you're dropping the cellular payload exactly on that coordinate.
Exactly.
But how does physically sprouting new nerves or building new blood vessels actually translate to a change in what the patient feels during intimacy?
It comes down to the mechanics of arousal, which relies heavily on vasocongestion.
Which is what exactly?
It's the rapid swelling of tissue with blood. Because you've physically expanded the microvascular network, the body can push more blood into the area much faster.
Oh, I see.
And simultaneously, because the nerve density is higher, the signaling to the brain is stronger. Patients report faster arousal, increased natural lubrication, and just heightened physical sensitivity, purely because the biological hardware responsible for those responses has been, well, regenerated.
So we've mapped out how PRP triggers the nerves. But this is where the deep dive takes a fascinating turn, because this exact same syringe of spun-down blood is also used to treat a completely different, purely mechanical issue,
Yes.
stress urinary incontinence, or SUI. This is the condition where involuntary leaks happen during a cough, a sneeze, or a heavy workout. And obviously, if we're trying to stop a bladder leak, injecting the nerve center of the clitoris isn't going to do anything.
Not a single thing. And this really illustrates the versatility of those growth factors. To address SUI, the needle must abandon the sensory nerves entirely and move to a structural support system. We are talking about the periurethral area.
So this is the hammock of tissue that holds everything in place, right?
Exactly. The urethra is the tube that carries urine out of the bladder, and is held in place by a complex sling of ligaments, fascia, and muscle.
Right.
When a woman coughs or jumps, The downward physical pressure on the bladder is immense. If the periurethral sling is strong, it provides a firm backboard. The urethra gets pressed against that firm muscle and pinches shut, completely preventing a leak.
Okay.
But due to childbirth, aging, or hormonal changes, those ligaments can stretch out and weaken.
So the backboard basically turns to mush. When you cough, the tube just gets pushed into soft tissue, it doesn't pinch shut, and you get a leak. So what does this all mean for the injection strategy? Are we basically using the PRP as organic spackle to patch up a weak wall?
That is a great visual, honestly. But instead of plastering over the wall, the PRP is instructing the body to rebuild the internal rebar.
Oh, interesting.
Yet, the injection strategy here requires significant depth. The practitioner must bypass the sensitive surface tissue entirely. They guide the needle into the anterior vaginal mucosa surrounding the mid-urethral region, pushing down to a depth of about 10 to 15 millimeters.
Wow, they really have to get down into the structural basement of the tissue.
Yes, they are targeting the actual fascia and ligaments. And just like the clitoris, it is a highly structured map. Practitioners will often inject at multiple points surrounding the urethral opening, sometimes mapped as the 2, 5, 7, and 10 o'clock positions.
More clock faces.
Exactly. Or they will distribute specific milliliters of serum directly to the midline and the lateral sides. The goal is to basically bathe that weakened ligament hammock in TGF-beta and those other growth factors.
To trigger the fibroblasts.
Right. This triggers massive fibroblast activity. Over weeks, the body lays down thick, fresh pillars of collagen and elastin. The sling tightens, the backboard becomes firm again, and that mechanical valve can finally hold shut against the pressure of a sneeze.
It is brilliant. I mean, we use the same cellular seeds, but because we planted them in structural tissue, they grew structural pillars instead of sensory nerves.
Exactly.
But the map has one more major destination, right? We've gone deep into the tissue, but we also have to look at the surface. Because the external mucosal skin of the vulva can suffer from some pretty brutal dermatological conditions.
Oh, absolutely. The clinical data spends a lot of time on conditions like postmenopausal vaginal atrophy, where a severe drop in estrogen causes the tissue to shrink, dry out, and become incredibly fragile.
Right.
There's also lichen sclerosis, which is a chronic inflammatory autoimmune condition where the skin of the genitals literally thins out like wet tissue paper. It leads to agonizing microtears and scarring.
And for these patients, the deep structural injections wouldn't make any sense. The problem is right there on the surface layer. So destination 3 takes the needle to the vulvar vestibule and the labia minora.
And this requires a completely different injection methodology. We aren't going 15 millimeters deep anymore. We are doing intradermal injections, meaning the needle stays right inside the dermal layer of the skin itself.
Okay.
One prominent clinical protocol details a very specific approach for covering this wide surface area, using something called a linear retrograde technique.
Okay, let me see if I'm visualizing this correctly. Is the linear retrograde technique basically like caulking a bathtub? Like you don't just squeeze the whole tube of caulk into one giant puddle. You press the nozzle in and you slowly pull the gun backward along the seam, leaving a smooth, continuous line behind you.
That is the exact mechanical motion, yes.
Mm-hmm.
The practitioner inserts the needle to its full length horizontally, just under the skin. Then, instead of pushing the plunger right away, they begin to slowly withdraw the needle, injecting the PRP smoothly as they pull back.
Wow.
It leaves a continuous thread of regenerative serum right inside the dermis. And they repeat this across the anterior, posterior, and lateral boundaries of the vestibule.
Which makes total sense for a skin condition.
Yeah.
You're blanketing a wide, fragile area with a lattice of growth factors, prompting the body to thicken the skin, restore moisture, and heal those agonizing microtears.
If we connect this to the bigger picture, it really highlights the absolute marvel of what this procedure represents. Think about the journey we just took. We are dealing with a single, uniform substance, the patient's own spun blood.
Yeah.
Yet it acts as a customized key that unlocks completely different doors, purely based on the anatomical lock it's placed into.
Inject it into the neurovascular hub at the clitoris, and you get explosive nerve sensitivity. Inject it deep into the fascia of the urethra, and you rebuild the muscular scaffolding to stop incontinence. Inject it in a shallow linear thread across the labia, and you reverse chronic skin degradation. I mean, the map is everything.
It is the ultimate expression of targeted regenerative medicine. The biology is waiting. It just needs a precise delivery of the signal.
Now, I have to ask the elephant in the room question. As we talk about needles being inserted into the clitoris, plunging deep into the urethra, and threading under the skin of the labia.
Yeah, the pain.
Right, anyone listening to you is naturally wondering about the pain. Getting a shot in the arm is one thing. Getting a shot in the most heavily innervated tissue of the human body sounds utterly terrifying.
It is the single most common concern patients have, and rightfully so. That is why the clinical protocols for the O-shot place a massive emphasis on a highly regimented numbing process. Long before a needle is ever introduced, the patient is treated with a specialized topical anesthetic.
The sources mention a high-strength compounding cream that sits on the tissue for up to an hour. There's a specific acronym they use, BLT cream.
Yes, BLT stands for benzocaine, lidocaine, and tetracaine. This is a highly potent trifecta of local anesthetics, usually formulated at much higher percentages, like 20% benzocaine, than anything you could find over the counter.
Right, you're not getting this at the drugstore.
No, the clinic compounds it specifically to penetrate mucosal tissue. And in addition to the BLT cream, practitioners will often apply localized ice or a vibrating distraction tool right near the ingestion site, just seconds before the needle goes in.
To kind of confuse the local pain receptors.
Exactly.
And according to the clinical outcome data, this prep actually works. Patients consistently report a pain level of around 2 out of 10. They describe it as a sensation of mild pressure or a slight pinch rather than severe, sharp pain. The ultra-thin 31-gauge needle causes minimal tissue trauma, which keeps the physical discomfort surprisingly low.
It is a highly tolerable procedure for the vast majority of patients. However, managing pain after the patient leaves the clinic introduces one of the most critical, completely non-negotiable rules of the entire O-shot protocol.
Yes, the aftercare rule regarding painkillers. And here's where it gets really interesting. Because what is your natural human instinct the day after a medical procedure? If you wake up feeling a little swollen, a little achy, your immediate instinct is to go to your medicine cabinet and swallow an ibuprofen or an aspirin to bring down the inflammation.
Which is exactly what you are strictly forbidden from doing. Patients are told they cannot take any NSAIDs, non-steroidal anti-inflammatory drugs, for 7 days prior to the procedure and 7 days after.
This raises an important question for a lot of people. Why? Why ban the most common pain relievers on Earth?
Well, to understand the ban, we have to go back to how platelets work. The very first step of the regenerative cascade we've been talking about is inflammation. When you inject PRP, those growth factors purposefully trigger a localized inflammatory response.
Oh, I see.
That microscopic swelling is the chemical flare gun shooting up into the sky, telling the body's stem cells, hey, we have a site under construction, send resources here immediately.
So the inflammation isn't a side effect of the healing. It is the required first step of the healing.
Precisely. NSAIDs are designed to chemically block that exact inflammatory pathway. Furthermore, drugs like aspirin physically alter the platelets themselves, rendering them incapable of fully degranulating.
So if you pop an Advil because you're feeling a little sore, you're basically acting like a firefighter spraying foam on the very flare gun you just paid thousands of dollars to shoot off.
That's exactly what you're doing.
You chemically deactivate the platelets, you stop the growth factors from releasing, you essentially kill the high-tech seeds right in the soil before they can even sprout.
You completely negate the biological mechanism of the procedure. If a patient experiences discomfort, they are advised to use acetaminophen, which acts on central pain receptors rather than peripheral inflammation, or to simply use a cold pack. You have to respect the body's inflammatory process. You cannot chemically suppress it if you want the tissue to regenerate.
It's such a fascinating biological paradox. To rebuild the body, you have to allow it to experience that micro level of controlled chaos first.
Exactly.
So, to synthesize everything we've uncovered in our deep dive for you today, the O-shot is light years away from a generic pelvic injection. It is an intensely deliberate, meticulously calculated anatomical map. Whether a practitioner is establishing a precise ring of blebs at 4 o'clock points around the clitoris to wake up dormant nerves,
Right.
or driving a needle deep into the fascial basement of the periurethral sling to construct organic rebar for bladder control, or executing a linear retrograde thread across the vestibule to rebuild the dermal barrier, location dictates the entire outcome. The magic isn't just in the blood, the magic is entirely dependent on the mouth.
And as we always like to reiterate, while the microscopic science of regenerative medicine is incredibly compelling, human anatomy is diverse, and individual responses will always vary. We always encourage you to consult a qualified medical professional to determine if a targeted procedure like this aligns with your specific physiological needs and health goals.
Absolutely. We started today talking about how precise GPS coordinates can trigger the human body to literally rebuild its own vascular and neural networks from scratch. So I want to leave you with a final thought to mull over as you go about your day.
Oh, I love these.
If medical science has now successfully mapped out how to regenerate the most complex, highly sensitive nerve clusters in the human body using nothing but the isolated proteins from our own veins, what other delicate, previously untreatable areas of human anatomy might be unlocked next by this kind of cellular mapping?
It's a great question.
Thank you so much for joining us on this deep dive. We'll see you next time.